I'd just like to welcome Associate Professor Glenn Reeves, who's the Medical Director of the Autoimmune Resource and Research Centre, also a clinical immunologist, looks after lots of lupus patients, lots of autoimmune patients. So today, due to our current situation with the wonderful COVID-19 situation, we've decided to distance and start a little program called the Lupus Lounge Learning. And today is the 10th in the series that we're running from the 1st to the 10th of May, which is culminating in this video on World Lupus Day, Sunday the May 10th. So today we're just going to talk about lupus, and it's the way that we can offer some awareness about lupus, but offer some insights into some of the areas of research that may be happening and any new advances in that. So welcome, thank you for agreeing to come and interview in my lounge room. So it is appropriate, Lupus Lounge Learning, here we go. So can you just briefly start off by telling us what lupus is?
Well, lupus is an autoimmune problem. Auto means self. So the immune system's normally designed, as you know, to attack outside agents. It senses danger, picks up the presence of bugs, and attacks through a very highly refined method, which is partly innate, which is what we call the foot soldiers that will respond. They shoot first and ask questions later, so to speak. And then we've got the adaptive immune response, which is where memory is generated. Now, that all works really well for viruses, for bacteria, but it doesn't work so well if it's turned against yourself. And that's what autoimmune means. And so you have a response of your frontline soldiers and your T cells and your B cells attacking parts of your body. And that can manifest with everything from arthritis to skin rash to various types of organ involvement and inflammation. And really, I think it's not that well known, the concept of autoimmunity, because it's better known by the little pieces that compose it. There's more than 100 autoimmune diseases, and they include things like multiple sclerosis, lupus, which we're here for today to talk about World Lupus Day, scleroderma, Sjogren's, vasculitis. So there's actually more than 100 conditions. Autoimmune affects 1 in 20, and lupus affects about 1 in 700 people. So lupus, in answer to your question, is a misguided, confused, dysregulated immune system, where in some ways you've got recognition of self structures that shouldn't be attacked. And other characteristic features would include skin rash, which is often triggered by sun. There can be joint pain. There's often circulation problems, particularly in the cold weather. There can be dryness of the eyes and mouth. There's actually a list of about 11 different characteristics which are dominated by joint, muscle, and skin problems, but also involve organ problems and drops in various cell numbers.
Yeah, I was going to ask you about symptoms, but you mentioned a number of different illnesses there. You talked about Sjogren's, scleroderma, arthritis, all of those things. Is there a combination of illnesses that you see most often, or coming together, I mean?
Coming together, well, our interest in the Autoimmune Resource Centre and my interest as an immunologist is in conditions where the immune system becomes confused, so the autoimmune problems. And it's interesting that if you've got one autoimmune problem, you are likely to have more than one. In fact, most people with autoimmunity, they have 3 conditions at least. So there can be a coalescence, and I do see patterns, like, for example, for the lupus patients, I often see dryness, I often see fatigue. There's often a component of joint pain which is kind of reminiscent of what you'd see with rheumatoid, but it's a non-deforming arthritis. There's a lot of cognitive fog, but that seems to be a feature of all of the autoimmune diseases, where I don't know whether, if you get the flu, you sometimes feel like you're not thinking clearly, you're thinking in a fog. Well, this is what people with lupus and other conditions are dealing with all the time. And so cognitive clarity is impaired, short-term memory, word finding issues, etc. So that, yeah, in answer to your question, I'd say the sort of patterns I see, fatigue is universal.
Fatigue, yes.
Yeah. Cognitive clouding is common. Dryness is often a feature. Cold extremities to the point where people get really distressed by cold weather. And then on top of that, the features I mentioned, which can be skin rash, joint pain, and occasionally organ involvement, which might involve the kidneys or other organs.
So I've heard before about the photosensitivity and another symptom called alopecia or losing hair. Is that something of the illness, or is that something related to some of the treatments, the medications that people are placed on?
Well, it can be either, and sometimes it can be a trap or a real challenge to work out whether our treatment or whether the condition is causing the problem. And we face that dilemma daily. For example, Plaquenil, which we'll talk more about later, I'm sure, and which President Trump has made us all very aware of, otherwise known as hydroxychloroquine, is rarely associated with hair loss, but we also use it to treat hair loss. And it takes about 4 to 6 weeks to kick in. So we see a person, they're losing hair. It's part of a lupus spectrum. We say, let's try the Plaquenil. And 3 weeks later, we get the phone call, I'm still losing my hair. And so I'm saying, well, try and keep the faith because this might take 6 weeks. So there is a little bit of empiricism. There's a little bit of trial and error. Similarly, a lot of the drugs we use for lupus and related problems, unfortunately, they do have side effects, and it can be difficult to know which is the cause and which is the drug. For example, you mentioned sun sensitivity. Well, a lot of drugs are sun sensitizing as well. And our viewers would be aware of the little red or red label that they put on saying, do not limit your sun exposure with the following drug. And that's reported with doxycycline, but strangely it is reported too with Plaquenil. So you might be treating a person who's already photosensitive with a drug that might theoretically make them more photosensitive. So in our initial discussion with our patients, we normally discuss that and we ask them to watch out that paradoxical things can happen. Sometimes side effects of the drugs can be very similar to some of the symptoms of the lupus itself, so it needs to be treated with care.
Well, we were going to talk about medications and that later, but you've already spoken about steroidal medication, hydroxychloroquine. How would you describe the other treatments that might be available currently for lupus patients?
Well, we may be talking later about future directions. I don't want to steal the thunder from that.
But currently, what is available in the general?
Currently, we've got a number of broad therapies, and let's not confine ourselves just to pharmacological treatments. Let's remember that lifestyle is very important in the management of any chronic illness. And so we encourage people to have a healthy exercise routine, to eat a nice balanced diet, relatively low in additives and preservatives, having lots of good omega-3 anti-inflammatory products in their diet. So there's the diet, exercise, adequate sleep hygiene, and mindfulness, which is that fancy term that we all kick around, which is basically being aware of the moment and listening to your body. And if you're getting stressed, then trying to deal with that with active maneuvers. So they're the non-pharmacological approaches. There's others we could talk about like Tai Chi, Qigong, but we won't now. We could cover the whole hour just with those. Then we'd move on to symptomatic therapy. So if you've got pain, We don't want to crack a walnut with a hammer. We don't want pain to be treated with a toxic drug if we can help it. So paracetamol is extremely good. And the slow release Panadol, which you take 2 tablets of up to 3 times a day, can help control mild pain. Some people need anti-inflammatory drugs, and they have to be used with care because they can irritate the stomach or cause kidney toxicity, although some of the newer classes like Celebrex, celecoxib and that family, the so-called COX-2 blockers, they're said to be a bit more benign. Then we move on to steroids, which are excellent. In fact, they're miraculous in their effects on inflammation. And if you could tap the benefit and take away the side effects, it would be brilliant. But everyone knows that long-term steroid use, particularly at high doses, is a bad idea because it can cause bone thinning, blood pressure, diabetic, whole host of side effects that we don't want.
So many of the treatments that are being offered now are steroid-sparing drugs, or is that what they're main?
Yep, we're moving more onto steroid sparing, and that just means a drug that does the job of the steroid, but with less of those side effects that we've mentioned, less of the cholesterol, diabetes, blood pressure, bone thinning. And the steroid-sparing drugs can be either immune modulators or immune suppressors, or they can be biological agents. So let's go through them one by one.
That would be great.
Yeah. So there's immune modulators, and Plaquenil stands on its own as a modulator because it doesn't suppress your immune system. So you can take Plaquenil and rest assured that even though it won't cure COVID, I don't believe, although I may be proven wrong later, it will not increase your chance of infection. And if anything, it won't affect vaccination responses and a whole lot of other things. So you're not immunodeficient as a result of taking it. It cleverly changes the way your immune system works so that you're not handling self structures in a way that the body wants to attack them. Okay, so that's class 1. Then we get on to immune suppressors. Now, immune suppressors are usually repurposed drugs that might have been first used for chemotherapy or for renal transplant and have now been adapted to suppress the exuberant immune response of people with autoimmune problems like lupus. Examples of those, and I can use generic or trade names, but they'd be known as Imuran, which is azathioprine, methotrexate, which is methotrexate, the Cellcept, which is mycophenolate, a whole host of others too. And they do increase your risk of infection, and some of them have effects on white cells and liver. So they require some degree of monitoring. But having said that, they do allow us to get the steroid dose down, and they allow excellent disease control. And when the dose is selected correctly, the risk of infection is not substantially higher. What we don't want is for people to be on doses of steroids greater than 10 milligrams for long periods of time. That seems to be a magic number, although the recent European League Against Rheumatism, which sounds like a sort of cartoon fan club designed to fight joint problems, but they're very active. And the EULAR put out guidelines saying 7.5 is our magic number. If you can get below 7.5 of prednisone, that's good. And they even put forward what's been a controversial statement. Until recently, it was believed that steroids are evil, right? And that was what we were taught at school. Steroids are evil, okay? And get off them at all costs. But there's now some evidence that maybe a lowish dose, like 5 milligrams, could be used with relative safety to prevent relapses of these conditions.
So do you say with monitoring, when you talk about relative safety, with monitoring of like...
Monitoring of bone density,
yes.
blood pressure, cholesterol, eyes, because there can be changes in eye pressure, glucose, all of those things. So that's something EULAR recently introduced, whether that is, I think that's probably, we could put that in the controversial stage at this stage, but certainly coming back to your question, our goal is to find a way of a steroid dose of 20 milligrams might be fine for controlling lupus, but we can't do that forever. And so we try and get it down to 7.5 or 5, or preferably we try and withdraw it altogether, and we substitute one of these immune modulators, the immune suppressants rather, or the immune modulators. Interestingly, coming back to the EULAR recommendation, they say that everyone with lupus needs to be on Plaquenil.
Wow.
They just say, that's it, be on Plaquenil, but be careful of your dose. It should be 5 milligrams per kilogram.
So we've talked about a lot of medications, but we were talking about steroids, and I just, if you can, just talk about how steroids are used in a flare situation. And I've heard of the importance of making sure that you wean yourself off steroids when you're taking them as a pulse type.
Yes, well, steroids have such a multitude of uses for settling inflammation. Let's think of the person with asthma who uses steroids just for a moment. They might use, say, 40 milligrams and then drop over 5 days and they're off it. That's fine. It's when you're on it long term that you need to be careful about gradual weaning. Because if you're on more than 7.5 milligrams of prednisone every day, you switch off your own adrenal factory. It just sort of goes on strike, says, well, I don't need to make any more cortisol. This person's taking it by mouth. Now, if that person suddenly decided, well, I think steroids are evil, I'm going to stop them now, they would be in trouble because the adrenal takes quite a while to kick in. So anyone who's been on steroids for more than 7.5 milligrams for more than 2 to 3 months, you can assume their adrenal has functionally gone on strike, and those people need to have their steroids gradually weaned, and perhaps by 0.5 milligram or 1 milligram every fortnight. It can vary from person to person until then the body slowly can pick up the slack, the cortisol can get back into action, and everything's right again. There's argument about whether the physiological replacement dose, the equivalent of what the adrenal should make, is more like 5 or more like 7.5, but it's somewhere in that sort of ballpark. And so we were talking prednisone, and we were talking Plaquenil, and then we were talking about the different types of therapies that are used to try and get the steroid dose down. I got onto the immune suppressives, but I didn't actually touch on the biologicals.
Oh, right.
So,
Okay.
so just quickly there's a whole lot of things where we're trying to tease out exactly what are the mechanisms of lupus and then intervene specifically. And one that we might talk about later, if you're kind enough to ask me about it, would be the B cell blocker called belimumab, which Benlysta, which sort of blocks the B cells. B cells are the cells that make the antibodies that cause the some of the aspects of the illness. So,
Well, I think that's quite topical because am I right in saying that there have not until recently been any really new drugs available for lupus patients, but Benlysta was sprouted, I guess, as being one of the game changers. So let's talk about Benlysta and some of the new drugs that are there.
yeah, well, first to set the context, lupus falls in a sad place because it's not as common as rheumatoid. Rheumatoid affects 1 in 100 people, so there is a financial incentive for pharmaceutical companies to look for therapies because they know they're going to be selling it to 1/100th of the world population, which is quite a lot of people. When you're getting to something that's 1 in 700, maybe less motivation. But the other big thing is that lupus is so heterogeneous. And so when you do trials on drugs, you are sometimes including a whole bunch of people who are quite different. If you're trying, for example, a study of a new drug X, you've got maybe some people have dominant skin disease, some people have kidney disease, some people have blood problems, and they may all be micro subsections of different aspects of lupus who should actually really be analysed separately. But they're all thrown in together. They're often on steroids, so there is a diluting effect which puts the drug trial, the people who are bold and noble enough to actually explore lupus drugs, puts them at an immediate disadvantage. But with Benlysta, which was designed to block B cells, there have been some studies, and it is now part of the recommendations for treatment for lupus in certain settings. It's been shown to be good for particularly severe musculoskeletal and skin problems, so joint and skin problems.
Okay.
It's not been explored in people with brain or kidney lupus, so they've been specifically excluded up till now. But even now, the rheumatology associations are starting to say it could be considered as add-on therapy if, say, steroid plus Imiran or steroid plus mycophenolate isn't enough. So there's a bit of a full circle coming. There was, and I was one of them, I must confess, I was disappointed with the original studies with Benlysta, which blocks a chemical called Bliss, which we all need a bit more of, but it's a B lymphocyte stimulator. The studies were not dramatic, but the problem was that a lot of people were on varying doses of steroids, so it clouded the baseline level of activity. But we are seeing more and more that this agent has a role, and now pharmaceutical companies are investing in other blockers. Another one you might have heard of is a thing that blocks interferon. Interferon's very important, as the name implies. It interferes with viral infection. It's actually very important with COVID.
Wow.
Yeah.
I didn't know that's where the name came from.
Yeah, so it's an antiviral product, but interferon is released in huge amounts in lupus patients. And so we're looking at ways of blocking interferon. And there's a thing called anifrolumab, or they try and make the drugs so that you have to sort of trip over them and that you can't pronounce them if you've had a drink. Anifrolumab is an anti-interferon therapy which seems to be offering benefit in certain subsets of lupus. And there are other small molecule blockers, things that block signalling pathways like JAK and STAT. And we've spoken about baricitinib, not Barry, but baricitinib. And we've also talked about a whole range of other therapies. One group that I should emphasize, which seems to be quite exciting, and it's repurposing drugs that have been around for a while. We've spoken about Plaquenil, which was designed as an anti-malarial, but calcineurin inhibitors, things like tacrolimus, there's another related product. These are being increasingly used in renal lupus with good effect. So we're going to be seeing a lot more use of agents that we use for other purposes in combination with existing therapies in order to treat to target, which is what the buzzword is at the moment. We want to try and achieve complete disease control. We want to stop end organ damage. We want to prevent relapses. We want to minimize drug toxicity, and we want to improve quality of life. Quality of life is a huge goal in all of these therapies. I mean, it's no good saving someone's kidney, but killing the rest of their body with toxicity. It's just,
that's true.
Yeah.
So, are there any other advances or any exciting research areas that you'd like to touch on now? Tell us about.
Yeah, I've been really impressed by a number of things. First of all, the really important emphasis on the routine use of Plaquenil. when I first started practicing immunology, Plaquenil was perhaps seen as an optional add-on, a mild sort of do it if you want sort of drug, but now it's being seen as an essential part of therapy, which is why we were very frightened when there was a hiatus related to the COVID recently, but thankfully that seems to be being overcome. The era of biological agents is coming. By biological, we mean things that have been designed specifically as antibodies that target specific pathways important in the production of lupus. Everything from depleting or blocking B cells, which make the pathogenic antibodies, to blocking T cell signaling, because T cells provide help to the B cells to make the antibodies, to interfering with specific cytokines or signaling pathways. Another thing that we're going to see more and more of is emphasis upon quality of life, and we're going to see a lot more emphasis upon proper and thoughtful trial design, so that we don't dilute out a potential benefit of a drug by including too heterogeneous a population, too mixed a population. So the trials are going to have to be thought through much more carefully. We're going to have to control for background steroid dose, because a lot of these trials, people have been allowed to use steroids up and down during the course of their treatment, so you can't tease out whether the drug's helping or whether it's just their steroid bursts. They'd be the key things. Another important thing I would say is that we are moving more towards a multidisciplinary approach. In other words, we are encouraging the collaboration of immunologists, rheumatologists, nephrologists, dermatologists, everyone who sees different parts of the elephant, so to speak. You know, you've heard that analogy where, you know, you can analyze an elephant, and if you're a blind man feeling the back, you feel this thin tail-like thing, and then if you're a blind man feeling the trunk, you feel something different. Well, we're actually blind people trying to find different aspects of lupus, and
it's about putting all those jigsaws together.
It's a matter of putting all that together. Yeah.
Nice analogy. Yeah.
Yeah.
Yeah, so, well, I mean, the biologicals is something that I saw with my own mother with rheumatoid, which was a game changer for her. So hopefully we will, in people that have lupus, will see the same sort of response. Now, we haven't at this stage talked about the actual diagnosis of lupus. So how, I mean, we've said that lupus is you've said that lupus is quite a heterogeneous illness, and it has many different symptoms, and that symptom spectrum could be different with each person. But I mean, how is it diagnosed?
It's diagnosed by first thinking about it, and sadly it takes an average of 4 to 5 medical visits before the penny drops. And it may take 4 to 5 years before the diagnosis is made. The reason for that is that often the symptoms are quite non-specific and things that we'll all suffer from time to time. So, for example, the fatigue, the cognitive clouding we discussed before, the aches and pains, all of those things could be attributed, particularly in a young woman. Remember, this condition affects 9 women for every 1 man. It may be put down to a busy life, trying to run the household, being stressed, perhaps somatizing, which means turning psychological distress into physical symptoms. And so first think about it, and then look for clues. And the clues are sun-sensitive rash, particularly over the cheeks. Ask about joint pain, but a special type of joint pain. It should be symmetrical, so usually small joint, both hands. It's usually something you wake up with, so it's not something that's made worse by use, which is more osteoarthritis. You wake up stiff, it takes you a while to get moving. Then you ask about dryness and Raynaud's, which is where your hands go white, blue and red in the cold weather. You look carefully at kidney sediment to make sure there's no renal involvement. You ask about pleurisy, and you look for cell changes. Then, okay, now you've thought could this be lupus? And we should always be asking that because it's the great imitator. It can present in so many different ways. How do we check for it? We ask for an ANA, and that's an anti-nuclear antibody. So we were talking about how the immune system's confused. Well, we've got ANAs that have to be there to make a diagnosis of lupus. People talk about ANA negative lupus, but that's extremely controversial. I don't believe that it's very common, with one exception, that is if you've got skin lupus, you can sometimes be ANA negative but positive for a thing called SSA. But for all intents and purposes, do an ANA. If it's negative, you're probably barking up the wrong tree. If it's positive, however, that doesn't prove that you've got lupus. You need the clinical story as well. Because if I took 100 people off the street and did an ANA on them, I'd find 20 healthy people with positive anti-nuclear antibodies who don't have lupus. So tests are good, but they're not the be-all and end-all. We need history is about 80% of the diagnosis, and the rest of it is examination and investigation, not the other way around. But that's the bottom line for diagnosing, and particularly looking carefully for signs of end organ damage or cell problems, and also looking for a so-called clotting factor called phospholipid antibody, which is seen in about a third of people with lupus and can manifest with recurrent miscarriage, clotting events, or low platelet counts.
So do you think that that goes into where we are, the prevalence and the prevalence age, where we see a lot of people diagnosed in their early 20s and 30s and that? Do you think that antiphospholipid and the miscarriages and that is why we're seeing such a high prevalence there, or are there other reasons for that?
So in terms of the pathogenesis, I have been guilty in the past of oversimplifying the reason why this affects women. I'd always fallen for the estrogen theory, which is popular, isn't it? Because women have estrogen, right? Blokes have testosterone. Testosterone, if anything, is a bit immunosuppressive. Estrogen stimulates the immune system, but you know, there's some growing evidence that X chromosome seems to be the answer. So there's a lot of immune genes expressed on the X chromosome that are important for critical factors in immune responses. And even though the woman has two X's, one of which is largely inactivated, little bits of that second X are still there. So they've actually got a double dose, or at least an extra dose of some proteins. And we actually think that that might be part of the reason why, A, they are more prone to autoimmune disease, and B, they're less prone to COVID, but that's another story.
Really?
Yeah. So yeah, coming back to the miscarriage story, yeah, I think anyone with recurrent miscarriages should be have their lupus looked at. And sadly, this is a condition of young women in their childbearing years often. And so we need to be mindful of that.
So when we were talking, you were talking about like end-stage organ damage and long-term organ damage. Is that, when you think about managing a lupus patient, and we've spoken about medications and also self-management, the importance of that. What other aspects of management are important on a monitoring sort of level for a patient?
Depending, as we said, lupus comes in many shapes and shades. Some people have very stable, quiet autoimmune problems which dominantly involve their skin. And for those people, the likelihood of it suddenly becoming a dramatic, raging renal lupus is very low. So for those people, perhaps it may suffice for regular primary care visits for their routine health care, and perhaps touching base with an immunorheumatologist once a year. On the other hand, if you've got someone who's had a history of active involvement that's threatened their organs, then those people are going to need to be watched more carefully, and that's going to involve looking at markers of inflammation in the blood, complements which go down in active lupus, DNA antibodies which often go up, and looking for traces of protein or casts in the urine, which might be a sign of active renal lupus. So it's not a one-size-fits-all, but I do think two important points to be made there. One is that education at a patient level is critical, and that they know that not all lupus is the same. It's often not life-threatening or sinister or dire. It can be compatible with a good outcome. In fact, some people can go into remission. The second thing is, I think we're moving away from a paternalistic approach to medicine, more towards, if not a patient-driven approach, then at least a partnership approach where the doctor and the patient negotiate what they both want in terms of quality of life and outcomes. And finally, I would suggest that people need to try and maintain a positive outlook, because the catastrophizing effect of a diagnosis of lupus, it can take on a life of its own and lead to secondary reactive depression and mood disturbance.
I think that they're looking after your mental health as well as your physical health is very, very important. And I think we've learnt lots today. I've learnt lots today in that as well. So taking that last point about looking after your mental health and your physical health, and I think that's important for people that look after lupus patients and that as well. So tell me, what do you do to look after your own mental health and physical health?
Well, I do origami, which is which I happen to be a black belt in.
Black belt in origami.
In origami, and that involves the art of paper folding. And if I could give you an example here, is this of any use to you?
No, they were my notes, but that's fine.
All right. Okay, so
this is almost like a magic trick, Glenn.
Okay, so that's a square piece of paper. You can all see that. So I'm going to now fold it and form what we call the bird base, which involves folding these things. So this is what I do for relaxation. I fold pieces of paper and I make things like birds. So there's the bird base. This will be quite a deformed bird, but nevertheless you'll get the idea.
We welcome all animals into this household, regardless of their illness.
So there's the bird's head.
Oh, of course, I can see it happening.
And there's the bird's tail. And I've done better work, but this is something I've done on the fly, so to speak. And this is the bird's wings, which will make like that. And now the beauty of this bird is that it can, maybe not well, but it can fly. Let's just see if we can make it fly. Well, his wings are sort of flapping, but yeah, I've done better work. But that's one of the things. The other things, I go out on my boat and I play with my dogs and I spend time with my family, and yeah.
You got anything else before we end? Anything that you'd like to add?
One other thing, that is that people with lupus have a 5-fold increase in cardiac disease. So as part of what you're asking me before, it's very important to maintain close contact with your primary carer to aggressively control vascular risk factors, because it's doubly important, if not triply important, to make sure you've got perfect blood pressure, cholesterol, and that your heart is checked out. And if there is an indication for aspirin, then that should be used too.
Thank you for adding that.
Yeah.
Well, thank you again. I mean, this will be aired on World Lupus Day on May the 10th, which just happens also to be Mother's Day here in Australia. So Happy Mother's Day to everybody. Happy Mother's Day to your wife, your children, who I know also have children, and that now. So thank you again for spending your day talking to us, and thank you. Happy World Lupus Day.
Thank you for having me, and happy World Lupus Day, everyone. Remember that we're in exciting times. Things are getting better, particularly once COVID's behind us. But thanks for asking me to talk today. I've enjoyed it.